Clinical diagnosis often focuses on the individual, treating illness as a failure of internal biology or personal lifestyle choices. The Dahlgren and Whitehead model shows individual factors sit at the center of a wider network. Age and genetics are surrounded by concentric layers of social conditions that dictate baseline health. Isolating the working conditions sector reveals a massive, overlooked driver of chronic disease. Statistics from the Health and Safety Executive indicate that over half of all occupational ill health is directly attributed to work-related stress. The economic impact of this pathogenesis is significant, with an estimated 22.1 million working days lost annually in the UK due to stress-related conditions. The work environment acts as a structural pathogen, capable of both causing new conditions and making existing biological and psychological illnesses worse. In an occupational context, stress refers to a specific, chronic physiological reaction to excessive pressures or demands placed on a worker. Chronic exposure to this pressure manifests in severe physical outcomes, specifically cardiovascular disease and clinical hypertension. The parallel psychological morbidity is equally severe, leading to clinical depression, anxiety, and occupational burnout. Effective prevention requires identifying the exact structural mechanisms translating job design into biological and psychological damage. The primary tool for predicting this morbidity is the Parasec job strain model, which uses an epidemiological approach to assess the workplace. The model identifies three variables: job demand, the objective physical and psychological pressures on a worker, and job control, measuring autonomy. Control means decision authority and skill discretion. Plotting these creates a quadrant, with the bottom right representing the high strain zone. High-demand roles become pathological when paired with low internal agency. If a worker has autonomy to manage a heavy workload, the environment promotes learning. A third variable, social support, modifies this risk. Backing from colleagues buffers high strain, while lack of support exacerbates it. Longitudinal studies by Marmot and Bosma on thousands of civil servants have provided empirical weight to this framework. Their research showed that low job control was directly associated with raised levels of stress and increased mortality from coronary heart disease. Kivimäki reached similar conclusions while studying public organizations in Finland. Kivimäki's data revealed that increased sickness absence was mediated by high demands and a lowering of job control. The demand control support model serves as a proven epidemiological predictor of physical mortality and long-term health decline. If job design is indeed the primary pathogen, we must account for why certain demographics suffer vastly different rates of illness within the same economic systems. Data from the Health and Safety Executive shows that females have statistically significant higher levels of work-related stress, depression, or anxiety compared to males across all age groups. These disparities map directly onto the axes of the DCS model through the lens of intersectionality. Women often face higher domestic and caring responsibilities, which increases the demand variable, while workplace sexism often limits promotion to positions of authority, driving down the control and support variables. However, treating stress exactly like an epidemiological disease overlooks a key psychological factor. A purely physical pathogen, like asbestos, causes biological damage through direct exposure, regardless of the person's beliefs or perceptions. Wainwright and Kalnin argue that psychosocial factors are different, as they are mediated by human consciousness, cognitive appraisal, and subjective perception. Occupational pathogenesis results from an objective structural failure that is ultimately filtered through a subjective human experience. Many organizations respond to high burnout rates by focusing on individual coping mechanisms and wellness programs. Placing the burden of mitigation entirely on the worker often fails to address the underlying causes of the problem. Individual health initiatives frequently leave the pathological demand, control, and support levers of the job design untouched. The variables of job strain remain separate from the constitutional factors of the individual. Systemic change requires engineering the toxins out of the environment, rather than training workers to withstand them. The healthcare sector demonstrates an environment where occupational strain has immediate, high-stakes consequences. Patient safety depends on clinician vigilance and quick thinking, factors that are easily compromised by high-strain job designs. The magnet model provides a proven framework for systemic organizational design in nursing. The model restructures the workplace to increase worker autonomy and institutional backing, directly addressing the variables of control and support. This intervention leads to measurable outcomes, including drastically reduced burnout rates and a lower intent for staff to leave the profession. Engineering resilient work environments functions as a foundational medical intervention that supports both clinician well-being